Okay, hi everyone, and welcome to the April Cost Growth Target Technical Advisory Group meeting. Um, we can go to the next slide, please. So just a quick overview of our agenda today. It's a rather short-looking agenda. We'll see how long it takes. I'm guessing it won't take the whole 2 hours that we've reserved. But we are going to have a few program updates, and then the main agenda item is to look at updates, draft updates to the 2025 data specification manual for the cost growth target data submission, and also the updates that we have made to the submission template. This is basically to follow up on our last meeting when we kind of proposed the list and discussed them. This time we are going to look at the actual draft documents and give you all another 2 weeks or so to look at them yourselves if you want to. And then we will touch base on the next meeting. Next slide, please. Program updates. I think we can go to the slide after that. So this is just an update on our recruitment for the Affordability Committee and Industry Advisory Committee. If you recall, the Affordability Committee is being started up by the Oregon Health Policy Board. This committee is going to focus on looking at policies that could improve healthcare affordability in Oregon. It's to some extent replacing the old Cost Growth Target Advisory Committee, but then also expanding on its mandate beyond just the Cost Growth Target program. So we had an initial round of recruitment that had opened or had been due, I believe, April 11th. We didn't quite get the membership mix that we wanted, so we are going to be reopening recruitment for both the Affordability Committee and the Industry Advisory Committee. If you had already submitted an application for either of these, you don't have to resubmit. We're keeping everyone in the mix who had already submitted an application to be on the committee. But if you are interested in submitting an application and didn't get to do that by April 11th, I believe we're probably going to reopen the recruitment by the end of the week. We'll try to send out a message when we do that. Next slide, please. And this is just a reminder of what sort of membership we're looking for on the Affordability Committee, which is kind of the main committee, and then the Industry Advisory Committee, which will be obviously in an advisory role to the Affordability Committee. A lot of the individuals on this call might be great to have on the Industry Advisory Committee, as I believe you're mostly representing industry. So we would love to have some applications from people who have been working with the Cost Growth Target program. Next slide, please. This is a reminder that our annual public hearing is slotted to happen on Tuesday, June 10th. So in about a month and a half. Keep it on your calendar and we hope that you can join. Next slide, please. This is a quick update on 2024 provider cost growth target data validation. So this is, we have been meeting with provider organizations over the last couple of months. We had identified 54 provider organizations for inclusion in the program this year. And as of today, we had met with, I believe, 36 entities. That is basically all of the ones we're meeting with this year. I think we were concentrating on meeting with entities that were over the target, and also some that were just interested in validating their data. We are awaiting some resubmissions from a couple of payers currently that are correcting issues based on concerns that were identified during the provider organization meetings. So we're hoping to wrap that up soon and be able to validate all provider organization data. Next slide, please. This is a new update as of this week. Those of you who are going to be submitting data for 2025 should be receiving notifications in the next couple of days. We have mandatory payer data submissions, the mandatory payer data submitters of CGT1 cost growth data have been identified using enrollment data from DCBS and from Medicaid CCO enrollment data. So you should be receiving those notifications if you're on the list this year. I believe the list is basically the same as it was in previous years. But of course, if you have any questions when you receive your notification, let us know. CGT4 frontline workforce compensation data is going to be on its correct sort of timeline this year. Last year, all of those submissions were due in December because we had a little bit of a delay in rulemaking not being finished until July. This year, you're going to have the CGT4 data due around the same time, on the same day, basically, as the CGT1 cost growth target data. So if you are a mandatory reporter of CGT4, you should be receiving a notification from us. And for both of these, the data submitter lists have been posted online. There's also going to be a list of voluntary submitters for both of those data submissions as well, and we'll be sending out a message if you're a voluntary data submitter. Does anyone have any questions? I have kind of gone through all of these fairly quickly. Okay. Looks like no questions. Great. So next slide, please. Yeah, so that is all of the program updates that we had for you today. Hopefully not too overwhelming. And our next agenda item is to take a look at the updates that we made to the CGT1 data submission materials. If you recall, last meeting, we had shared a list of proposed updates to the data submission manual and the data submission template. This meeting, we're going to be looking at the actual draft updates. It's basically the same updates as we had discussed in the last meeting with a few small additions. And then in terms of follow-up to this meeting, I had only posted and sent out those draft materials yesterday. So we want to give you a little bit of time to actually look at them if you want to. So we're asking that folks after this meeting, if you want to email us additional feedback beyond what was expressed in this meeting, please do so by May 9th to the healthcare cost growth target data. So Annette, I'm going to share my screen. Let me pull up the data submission manual. And folks see the data submission manual document. Could someone just confirm that you can see the manual, and then I can start going
Yeah,
through?
we can see the manual.
Okay, cool. Okay. So here's updated manual. It's going to be version 5.0. For those of you who might be opening the document by yourself, there's a lot of little formatting updates that I made based on some updates to our branding. Obviously, that's not.
Hey, Margaret.
Yeah.
I just want to make sure everybody knows to go up to Margaret's screen at the top. If you can't, there's two screens that you can be seeing.
Oh, okay.
You just have to
Annette, do
click
you
Margaret
want to
Monroe's
stop
screen.
sharing the slides, maybe, if you're still sharing them?
Yeah, let me unshare real quick.
Okay.
Thank you. Sorry about that.
No, thanks for pointing that out. I don't think
Okay, now we're good.
Yeah, technology is always a challenge. Okay, So I had everything in track changes, so I basically was just going to scroll through the document and kind of look at the track changes. This initial change was just a change I made to the what we are reporting on. I believe we had probably made this section before we actually wrote an annual report, and we've been reporting on at the statewide and the market level cost growth in the annual report has been we've been reporting on it in a per person per year basis, but the manual was referencing PMPM data, which we do use PMPM data to report cost growth target data, but only at the payer and provider level in the annual report. And there was also no mention of the other spending that we've used. So this is really just kind of a technical update to make those changes and sort of align it with what we've actually been reporting on. Included population. So this is one of the changes that we mentioned during the last meeting. We'd had some questions about how to report on student health plan populations from payers, since students may sometimes have one residency that's their permanent residence, maybe at their parents' house in a different state or something like that. And they may be going to an Oregon university. So to the extent that you're able, if you have a student health plan that's for an Oregon university, we want you to be including any costs through that plan for the duration of the plan in the cost growth target data, counting those individuals as Oregon residents, even if they might have a permanent residency out of state. Any questions on this update? Hopefully it's fairly straightforward. If you had some sort of reporting issues with that, you could, depending on the level of granularity that you have in your own data around folks' residency, we could discuss it. Okay, the next change, I believe this was just sort of a minor moving things around change, so we can kind of scroll past it. So this is a new change relative to the last meeting and based on some back and forth we had with one provider recently. This is in reference to the IPA or contract name field that we added last year. If you recall, the idea is that in some cases, an attributed population might have both a provider organization that's actually providing PCP care, but then an IPA where the rates maybe are negotiated for that provider organization through an IPA. So, when you have that information, we want you to put the IPA in the IPA or contract name field. Same thing for total cost of care contracts. We had one case where it came up that a payer had kind of two separate attribution processes going on. One was for assigning someone to a provider organization where they're getting care based on a utilization algorithm. But then they also had a, member selection contract arrangement at the IPA level. We just wanted to specify that in the case that the attribution method used for a total cost of care contract or IPA is different from the way that you're actually assigning members to a provider organization, we would like you to put in the attribution tier field the attribution methodology that you used for the provider organization rather than the IPA or contract. Does anyone have any questions on that? Okay. I believe the next changes were just kind of updating our example reporting years, something more recent. Also on the IPA or contract field, Last year, when we sort of piloted this field, we had said that using the field was optional, although we encouraged you to use it if you had the data, because we might then, during attribution discussions with provider organizations, end up wanting to go back and have you add it anyways. This year, we're going to make the use of that field mandatory. So in the case that you have an IPA or contract name, as well as a provider organization, attributed provider organization name available, we're asking you to put that in there. We realize in some cases you may not be able to do that, but this year we're making it a requirement if you can do it, to do it. Any questions on that update? So this is just a clarification. In the case that the only information that you have is attribution to a total cost of care contract or an IPA, and you cannot attribute member months at the provider organization, PCP organization level, where you're unable to do that for some reason, we just added some language to clarify what to put in the TIN field. If you have a TIN that is specific to the contract or specific to the IPA, you can put that in the TIN field. But otherwise, if you're able to just make up a dummy TIN that would designate member months attributed to the contract or IPA, we would accept that as well. So that's in the case in this bottom total cost of care contract case where it was not able to break it down at the provider organization level. Next change was just a sort of minor phrasing change. We added physician's associate / assistant to the list of providers that we consider PCPs. That was based on a piece of legislation that was passed in Oregon in 2024 that sort of, for Oregon, redefined physician's assistant as a physician associate. So it's really just sort of a vocabulary change to make it extra clear what goes in that category. Stuff. I think I was just moving some stuff around here, so it's not an actual real change. Next change, we added health-related social needs to the list of items reported on by CCOs. Should be fairly straightforward. I believe a lot of those payments were coming online during this period. Any questions on the last few updates? This is just a clarification for non-claims that we want non-claims to be reported based on the incurred date or date of service and not the paid or reconciled date. And that was already in there, but I think we had a couple cases this year where payers had mentioned that they were putting, for example, if there was a performance payment based on 2022 performance, that payment was being recorded in 2023 when the payment was made. We just wanted to clarify that we would like the payments in those cases to be reported in the year for which they were based, the performance year that they were based on. Does anyone have any questions about that? That's, I think, a somewhat different change from ones we had discussed in the last TAG meeting.
Margaret, I have a question on that.
Sure.
So, in cases where the settlements are not finalized in the year, like in the incurred year, do you recommend that CCOs report like an estimate then?
Yeah, I mean, if we were hoping, I guess, that the run out period,
So I'm thinking more for the second year of the two.
yeah. I mean, we were hoping for that the run out period would give you enough time to process those. If that's not the case though, and you're able to estimate, I think that would be acceptable. That's a good, I mean, that is like sort of the natural question that comes up. So I think we can discuss a little bit internally and then hopefully have some guidance for you in the updated finalized version. Are there a lot of other payers for who they're not going to have a final number for, example, for this year, it's 2024 performance payments? Would you not have not have made the final payout for those 2024 performance year payments by September of 2025? I'm hearing a lot of responses. So I'm just going to make a note for myself in the document. And then I believe an estimate would be fine for us, but we can just double check internally if there's differing opinions among cost growth target team folks.
Okay, thank you.
Okay. So let's see. Yeah, this is just I'll go into a little bit more detail into this change in a minute. We had discussed last time performance payments and basically splitting the performance incentive payments field into performance payments and shared risk and savings settlements. So two different categories where there had been one. And then getting rid of the provider salaries category since almost no one has been using that. And also now, based on your feedback from the last meeting, adding health-related social needs category. So I just added that to the list, but we can go into a little bit more detail in a minute. Updated due dates to get rid of the 2024 due date. Okay. So this is the validation section describing the validation checks that we do. We added in a couple places for this year that we want you to have an authorized signatory re-sign the submission each time you do either a submission or a resubmission. We had some payers who had been doing resubmissions and not necessarily updating that each time. So we just wanted to make it clear that we would like you to do that. I'm going to scroll past a couple of these because they're just changes to validations that are in the template, and we're going to look at those together. This section is describing the validation checks that OHA is doing. We're looking to add a validation check this year to take a closer look at changes in attribution from submission to submission, like at the provider organization level. This isn't necessarily something that you would be able to do yourselves beforehand. But we have our list of provider organizations and their TINs, and our plan for this year is to add a validation check looking at changes in member months and probably spending by CGT accountable provider organization in each of your data submissions from the 2024 submission to the 2025 submission as a part of the payer validation process. We're hoping that this will help us catch some of these shifts that we've been having a lot of back and forth about the last few months. We did add a few provider organization validation checks last year, but they didn't catch everything that we've been finding the last few months. So we just want to try as much as we can to have an eye on shifts in attribution from submission to submission, especially for organizations that were accountable in previous years. And so we're adding that to our payer validation checks. So yeah, I mean, to the extent that before you do the submission, you're able to look for any changes in your attribution that might be useful in heading off some of these conversations and resubmissions as well. Any questions on that? This was just a sort of editorial update. I guess we forgot to add the medical pharmacy tabs to this list last year, so we added it. Another reminder to redo your attestation before submitting or resubmitting. Added CCOF to the lines of business. We added that in an update to the manual, I believe, last September. A little bit after the fact. This is going to be relevant only for CCOs and only in the TME all tabs. Same thing as last year, we'll have you reporting CCOF as LOB 7 in the TME all tab of the data submission template. So just formatting changes. Okay. Yes, so the non-claims payments updates. We just made a couple of updates to this section based on mostly the updates that I had mentioned a couple minutes ago. We did also add this clarification in the non-claims payments section that we do want you to be making an attempt to attribute non-claims payments in the same manner as you are attributing claims payments, i.e. at the member level. This might be a little bit more complicated potentially for non-claims when compared to claims, but the idea is that we want the non-claims payments for a given provider organization to be non-claims payments made on behalf of their attributed population. Which, in some cases, this might result in non-claims payments, mostly reflecting the payments that that provider organization itself received. But in some cases, it's also going to include non-claims payments that might have been made to other organizations, for example, specialist organizations, dental providers, or other specialty providers may have received a non-claim payment on behalf of a patient that was attributed to the provider organization, but is not the same as a provider organization. So this is just an edit to try to make that extra clear, because I think we had a couple cases where that wasn't completely the rule that was being followed. Any questions on that? Then the next big changes to the non-claims section are, as I said, we got rid of the performance incentive payments category, but the stuff that was under that category is now just being split out into two different subcategories. So that would be performance payments, which are payments that are made based on specific metrics that could be related to quality of care, patient outcomes, or data reporting, but cases where those payments are not involved in a shared risk or shared savings contract. Shared risk and savings settlements will then be in this separate category themselves. There had been a question at the last meeting about what a payer should do if they're not able to separate out those two types of payments. In that case, we want you to just make your best guess at where the majority of those payments would fall, whether it was shared risk and shared savings or performance incentive payments. and put it in that category. And maybe make a note on the in the cover page submission. Actually, I didn't add that, but I'm just going to make a note. Anyone have questions on that initially? Based on your feedback from last time, it sounded like so far health-related social needs payments are mostly coming through non-claims for the coming period. So we added a health-related social needs specific category for non-claims this year. We also got rid of the provider salaries category and then specified that any dollars that were previously being put in provider salaries could just go into the non-claims other category. And then for the recovery category, we mentioned this last time as well. We clarified the instructions for that category a little bit. So for any recoveries that are related to claims payments, for example, if you have an audit or something and recoveries were taken back, that should be netted out of the claims category that came from originally. Recovery is then just solely going to be all payments received from a provider, member, beneficiary, or other payer, which are distributed by a payer and then later recouped due to a review, audit, or investigation, but only through the non-claims system. Does anyone have any questions about the last few bullet points? Okay. I believe that might be the majority of the changes that we made. Let me just look at my list real quick. I believe that is all the major changes that we made. There's a few more changes in the document later on to update the data dictionary to have the new fields that we added and to include the list of updates. But overall, that's the main changes we made to the manual for this year. I'm not getting a lot of comments, so I think I'm going to reshare and share the updated template, which also had a few changes. Find it. And everyone see the updated template.
Yeah, we're good.
Great, thanks, Sam. Okay, so this is the updated template. The main changes that we did were to add some new validation tabs for medical pharmacy. I can go over that in a moment. We also added a few other validation checks and made a few other minor changes. So we updated our attestation language on the cover page with the full name, title, position, and like an actual space for signature, which can just be a typed name, I believe. Might need to clarify that internally, what we want in the signature field, but we'll do that and share it by the time we have the finalized version. No changes to TME all. We added a new, so this is all kind of related to the medical pharmacy validation that we added for this year, because this feeds into it. So this is a new little validation check at the top and to the side in the TME Prov tab. It's looking for basically cases where there is a combination of year, line of business, provider, and IPA and attribution level. So where there's like repeat values for reporting year, line of business, provider, IPA, attribution. We want everything to be rolled into a single line at that level. And there were a couple of cases in the submission last year where there was maybe 2 lines that had the exact same values for these, but with different member months and costs. We want it to be rolled up this year, and that's largely because it'll help the medical pharmacy validation checks to be accurately catching some of the issues that we encountered this year. So that's one check. It'll tell you how many issues, how many lines there are that are not unique, and then you'll be able to flag them in this column here. Then, of course, we added these 3 new categories that we were talking about earlier, fairly straightforward. I guess I can just, yeah, and then RX MedProv. So on the medical pharmacy tab, there is the same sort of search for combinations that are not that are being repeated. There's an additional one that is also looking for cases where there's a line that doesn't have a corresponding line in the TME Prov tab. So the overall issue that we had with a number of medical pharmacy submissions this year is that for each, like at the year, line of business, provider organization name, IPA contract field, attribution tier level, for every line that's in the RX Med Prov tab, there should be a corresponding line in the TME Prov tab. So these checks are going to help you look for cases where maybe there's a line in RX Med Prov that doesn't have a corresponding line in TME Prov, which is an issue because it would mean that what is in the medical pharmacy tab is not actually a subset of what is in the TME Prov tab. And we need it to be a subset so that we can report on medical pharmacy costs accurately at the provider organization level. Yeah, so that's the first check here, is looking for those combinations that are missing in TME Prov, which would indicate it's not a subset, and then doing sort of the same check for rows with repeated combinations. And you can kind of see where the two might be related. We had a couple of cases last year where our own code internally was sort of flagging. Well, actually, that's more related to the other check that I'll go into in a second. But if you have a number that's not 0 up here, you'll be able to go over and look and see where, like, what line is the issue. And then beyond there being lines in the medical pharmacy tab that don't have a corresponding line in the TME Prov tab, we are also going to be looking for lines where the total costs, the claims costs in the corresponding medical pharmacy line and TME Prov line, where the medical pharmacy line has a number that is greater than what is in the TME Prov line, which would also indicate that it's not a subset of what is in TME Prov. And to be able to do that, we needed all of the lines to be unique at the reporting year, line of business, provider organization name, IPA contract name, attribution hierarchy code level. So we're not like kind of mismatching lines and incorrectly flagging cases of medical pharmacy being higher than TME Prov when it's just not matching the correct lines. So this will do a row count at the top of lines and categories where the medical pharmacy is not a subset of TME Prov. And then I believe there's some code to flag, negative numbers where the difference is where medical pharmacy is larger than TME Prov. That'll be highlighted in red. And then there's kind of a similar check for the unattributed tabs as well. Does anyone have any questions on sort of the general concept of how the attribution, how these medical pharmacy validation checks are working? we're hoping that'll help to reduce the number of resubmissions we have related to medical pharmacy this year, since we had quite a few last year. You know, it was also a year of learning, I think, so hopefully you had already put whatever checks you needed in your system to prevent having that issue again, but this should be just like the final check before you do your submission. We also added a new table related to medical pharmacy to TME validation. That's basically just going to sum up all the costs across TME Prov and TME unattributed at the medical pharmacy level, and look at what percentage of each category at the line of business year level has been attributed to medical pharmacy cost. In general, we didn't really see for cases where medical pharmacy was making up more than around 35% or so of a given category's costs. So actually I need to update this language. I believe the cell is going to turn blue. If medical pharmacy, if the total attributed to medical pharmacy is greater than the total in that category in TME all, it'll turn the cell red. If the number is between, I think we started with 50%, but changed to 35% and 100%, that'll turn the cell blue. So basically the idea is medical pharmacy is probably not 35% or higher of a given category's total costs. So if that is the case, there might be some sort of coding issue going on that's attributing more to medical pharmacy than is actually the case, which was one issue that we had with a payer last year. So that'll be kind of just a qualitative ground truthing check on your side that you can do to look at what those percentages are. Any questions on that? Okay. I believe all the rest of this is the same. Added those new cost categories. And I believe that is the main changes that we had made to the template for this year. Okay, let's see if I can figure out how to stop sharing. Does anyone have any questions or thoughts, feedback for all? Stop sharing. Yeah, Travis.